pain suppression because of new regulation that increased oversight further complicates patient care. I am presenting today a method of treating chronic pain that can be used by any practitioner, has demonstrated outcome results, and does not involve the use of any type of pain medication. It has been my experience that chronic muscle spasm is the most frequent cause of chronic pain.
Sir, sorry for the interruption. We cannot see your slides.
They should be up.
Please share your screen, sir.
I did. I did share screen.
Yes, sir. Now we can see.
Is that okay now?
Yes, sir.
Good. Sorry. It has been my experience that chronic muscle spasm is the most frequent cause of chronic pain and is not generally responsive to typical anti-inflammatory agents or muscle relaxing agents. My clinical research was to find the cause of chronic muscle spasm and develop a lasting treatment, both of which were accomplished. What I discovered is that muscles that are in chronic spasm have sustained electrical activity, maintaining the spasm indefinitely. What is known as SEA, or spontaneous electrical activity, appears to be the result of the initial muscle contraction, squeezing off the muscle blood supply. If an overuse injury and muscle spasm is resolved in a few days, the muscle can tolerate the ischemic challenge and returns to normal. However, when the overuse injury continues, the ischemic challenge sets off electrical activity within the muscle that then maintains the spasm. Over time, there is gradual damage to the muscle with loss of mitochondria and muscle fibers. These changes have been found to be generally reversible, but can require months to occur. What was needed was a way to stop the SEA long enough for the muscle to relax. My findings took advantage of prior work, starting with the work of Travell and Simon's pioneering work on myofascial release and the experimental work of Hubbard with various agents to treat trigger points. I was successful in combining phenoxybenzamine with lidocaine to suppress SEA with long-lasting results. The injection procedure that I developed is named and trademarked as CMECD, Coletti method of chemodenervation. It is free to be used by any physician and can be used under FDA guidelines as an off-label use. It requires the use of an EMG device, which is the major limitation. The phenoxybenzamine, to which a small amount of a short-acting steroid dexamethasone is added, is available from a New Jersey pharmacy, Miller's of Wyckoff, to anywhere in the United States. The cost per patient is currently $60, and the cost of the EMG injection needle is $20. For those outside the US, phenoxybenzamine is available to any licensed pharmacy in the world from a company in Texas, USA, by the name of PCCA, and their contact email is clientcare@pccarx.com. On site, an equal volume of 2% lidocaine is added to the mixture before use. Current FDA regulations require the medication to be compounded for a specific patient and be used within 3 days. It is shipped overnight in cold packs and should be kept refrigerated. I have found that it can be frozen and have had successful results even after having been frozen for several years, although that is outside FDA guidelines. The fact is that I've used the frozen solution on myself as I had severe back chronic muscle spasms resulting from my caregiving to my wife subsequent to a prolonged hospitalization. The treatment requires EMG evaluation and simultaneous injection of areas of the muscle that demonstrate SEA. Very small aliquots of solution are injected into every area of the muscle that demonstrate SEA. The SEA is rapidly abolished thanks to the antiarrhythmic effects of the lidocaine and the SCA remains suppressed for prolonged periods thanks to the covalent bonding of phenoxybenzamine to the afferent alpha nerve receptor. The receptors are permanently disabled, and new receptors will replace them over weeks to months. The effective duration of action of the phenoxybenzamine is 2 to 3 months. This is enough time for the muscle to mostly recover. In this video, I am looking to treat the tensor fascial lata muscle that is responsible for the IT band syndrome. As I insert the needle, there is typical insertional activity in the normal muscle. When I find the tensor fascial lata muscle, you can appreciate the marked spontaneous electrical activity. The patient is at rest and without any voluntary activity. Also note that there is no evidence of discomfort from the needle insertion or injections. Phenoxybenzamine is an FDA-approved medication, now only seldom used in the early treatment of pheochromocytoma. It is an alpha blocker, and its systemic effect is to lower blood pressure. This needs to be taken into account, especially in individuals with low blood pressure or on blood pressure medications, as the systemic effects last up to 2 days. Phenoxybenzamine is also an irritant, and soreness at the site is not uncommon for several days. Dexamethasone was added to the mixture to minimize the irritant effect. What is most exciting about the procedure is the immediate and sustained relief of pain that accompanies the resolution of chronic muscle spasm. As one site is injected, it is not uncommon for the individual to recognize pain in another less severe site. This phenomenon, coined by my wife Kathleen as the hierarchy of pain, is critical to be aware of in any attempt to treat chronic pain. The physician needs to keep a record in a geographic manner to assess results. My first encounter with this phenomenon was when, after injecting one arm of a patient and having the patient then immediately state that his other arm now was painful. Thereafter, I took careful note and found this to be a near universal response to direct pain treatment. Backing up a bit, the question is, how do you know where to begin looking for the correct place to start? Obviously, the complaint of pain is the first step. Muscle and chronic spasm is tender to compression. Granted, there are some muscles, especially in the back, that are the cause of chronic pain and are too deep to compress. That aside, the majority of muscles in chronic spasm responsible for chronic pain can be found identified by response to compression. In some cases, the site of muscle spasm and the site of pain are at some distance one from another. The most common occurs with IT band syndrome, which is caused by spasm of the tensor fascial lata muscle in the upper mid-thigh, and the pain is generally at the knee. Cervical brachial syndrome is spasm of the scalene muscles, and the symptoms are mostly in the arm. I make use of the book, The Trigger Point Therapy Workbook by Claire and Amber Davis, as a starting point to identify muscles that generate pain at a distance. Muscles as deep as the psoas muscles can present with what feels to be superficial back pain. There's a learning curve to know how to find the source of pain, but whenever the injection relieves the pain, your search is ended. Treatment under FDA guidelines requires a consent form for an emergent procedure such as this. Should be extensive, identify the procedure as off-label, and name possible side effects. There is one on my website, CMECD.info. It probably could be revised at this point, but at least one is available for use. FDA also requires that the physician understand how the treatment works, which you now do, and keep track of complications. That is all that is required. In order to find true SCA, the patient needs to be put at full muscular rest, at least for the muscles being treated. Any voluntary muscular action can appear as SCA. I make use of a massage chair for most treatments of the back and neck. I also have come to only use a 3-inch needle to minimize skin punctures. This allows me to treat an area nearly 6 inches in diameter with a single skin puncture. Surprisingly, the penetration of the needle after passing the skin is well tolerated. It is important not to leave untreated islands of SCA. It is better to thoroughly suppress one geographic area at a time and return if necessary for adjacent areas. Complications with the procedure should be rare. Care needs to be taken when injecting muscles over the chest area to avoid penetration of the lungs that could cause a pneumothorax. Neck injections should keep in mind the carotids and vertebral arteries. Regarding anticoagulation, I have had no complications with patients on blood thinners, although needle sticks may require a bit of attention. I don't recommend you start with such patients, but should be aware that they can be potentially treated. I'm not getting sound. This is an EMG of normal muscle. It's what can be seen normal muscle at rest. There's minimal baseline activity, but no significant action potentials. One does not need to be an EMG expert to understand the significance of the basic EMG findings. The first thing you would notice is what's called insertional activity. When the needle penetrates the muscle, you will hear and see some activity. Normally, the activity is very brief and stops spontaneously immediately when the movement of the needle stops. However, sometimes the needle sets off a train of action potentials lasting a few seconds. This is called increased insertional activity. The finding of increased insertional activity, in my experience, is associated with muscle that is not yet in chronic spasm, but is demonstrating some membrane instability and may correspond to what may have been called latent trigger points. In any case, the most interestingly, insertions that set off increased insertional activity act like dry needling, and in some cases can cause the muscle to relax even without the injection. I had a few cases of this sort when I would not inject anything without classic spontaneous electrical activity, and the patients got better just from the attempts to find the non-existent SEA. Without going into details and discussion and theories, just know there is evidence that dry needling can reduce SEA, although not eliminate it. Multiple sessions may be adequate for treatment of chronic muscle spasm and pain, and EMG guidance has been shown to improve the outcome. The advantage of the CMECD procedure over dry needling is immediate relief and sustained effect with one injection. Return patient visits are therefore not guaranteed. For the primary care physician, however, this should be a blessing, not to have to continuously deal with the chronic pain. This slide demonstrates a typical SEA with a chaotic appearance. There are actually several types of electrical activity going on. The baseline noise, so to speak, is what has been identified as end plate noise. The end plate is where the final tip of the motor neuron attaches to the muscle fiber. There remains controversy over the actual origin of SEA, with identification of intrafusal and extrafusal origins. This pertains to the spindle, which is the sensory organ of the muscle, as a possible source of the SEA. Generally speaking, the extrafusal origin is accepted, meaning that the end plate noise is generated from the normal muscle fiber. The second element is the end plate spike. The amplitude of the end plate spike is thought to be adequate to cause contraction of muscle fibers, which the end plate noise is thought to be inadequate to do so. Other types of action potentials, including fibrillation potentials, have been reported. A significant type of action potential is the MUP, or motor unit potential. Although I recorded EMG signals for years, it was just recently that I had the opportunity to have an EMG expert identify an action potential that I mistakenly thought to be a fibrillation potential. This is a key finding in that it had never been reported either in trigger point literature or in any description of chronic muscle spasm. The presence of trains of MUPs seems to be present in more severe chronic muscle spasm. These action potentials represent activation of a larger muscle fiber and presumed contraction. Constant contraction of large muscle fibers can then be activated by MUPs. Helps us understand how the muscle is kept in a state of constant spasm. This finding also ties into the theory that I had proposed as the ischemic model of chronic muscle spasm, as prolonged ischemia is likely to lead to membrane instability and spontaneous depolarization. Normal muscle MUP are activated by voluntary activity. This is what you see after injection with virtually all of the end plate noise and other action potentials suppressed. It is similar to what you see in normal muscle at rest, essentially a flat line. Suppressed SEA with intermittent voluntary contraction, increasing intensity to show the muscle is still capable of contraction, but no MUPs were activated. Resolution of SEA with injection. This tracing shows the rapidity with which the injection resolves the SEA. I want to go over some of the outcome data that I compiled. This is the entire data set of a patient survey. I personally have treated over 200 patients and injected over 30 different muscles. I did a survey for the last 100 or so patients, and the data was compiled and statistically significant to the p less than 0.01 level was attained. This slide is way too busy, but the statistical findings were positive. Also demonstrated was the length of time the muscle had been in chronic spasm did not affect the success of the outcome. Often patients had chronic spasm for 1 to 5 years, but some had spasm for decades and yet had successful outcomes. What is most surprising is that in all but a few cases, only one injection was required. The same muscle was never injected twice, as that was never needed. Additional injection sessions were for other muscles that could not be injected with the limited dose provided for one session. The hierarchy of pain dictated that patients with chronic pain and chronic spasm may find another source and site of pain to be treated. Generally, I would have them wait 2 weeks before another injection to make sure that any original site discomfort had resolved and that the second site did not also resolve with normalization of gait or the like. In a paper published last year, chronic muscle spasm-induced chronic pain treated with CMECD procedure in the International Journal of Physical Medicine Rehabilitation, I included statements of patients that had been sent to my office detailing how the treatment had helped them. This is a bit unusual in a scientific paper, but I believed it was required for what I call the believability of the results. I recommend you take a look at it as an open access and no charge. I did succeed in publishing a book last year entitled Chronic Muscle Spasm and Pain, Discoveries in the Etiology, Identification, and Treatment of Chronic Muscle Spasm and Resulting Chronic Pain. It is available online, paper, or hard copy. I received no royalties to keep the cost down. The book is both a chronology of my 15-year clinical experience efforts and a do-it-yourself manual for the procedure. After a little experience, the procedure does not take much time and can be worked into normal patient hours. When I had a new patient referred to me, I allowed 1 hour for the review of the scans, such as MRIs, examination of the patient, full explanation of the procedure, and explanation of any questions from the consent form, injection of the patient, and assessing the results by having the patient move whatever hurt in the first place. For patients in your own practice, well known to you, and having your trust, it would take much less time. Having raised the issue of MRIs, I need to make clear that I never tried to view the actual MRI scans, as I am not an expert, and it is not a good idea to question the official radiological interpretation. However, I do ask for the MRI reports and when they're available. But I do tell my patients that I only read the adjectives, not the nouns. Words like mild and moderate when used in lumbar MRIs do not normally indicate a source for the chronic pain or sciatica. That would indicate that there is a reasonable chance that injecting or identifying spastic muscles may resolve the chronic pain or radiculopathy. Reports that state severe or critical would suggest injections may not be appropriate. What remains to be said is why I consider undertaking this treatment rather than sending the patient off to a pain management physician. To be clear, the pain management physician will have no procedure more successful than this one if chronic muscle spasm is the cause of the pain. Many times, all that is done is a controlled use of opioid medications. None of the patients I treated were given any pain medications. And with treatment, a significant percentage of them got off opioids or all pain medications. However, the most important reason to undertake learning and use of this procedure is the tremendous satisfaction of taking a patient out of chronic pain. A patient you will likely be seeing again and again with recurrent satisfaction and their gratitude. Not much is gratifying in medicine today, and this is one of the single exceptions. Thank you very much for your time and attention.
Is anybody is having any doubt, any questions they want to ask, so they can ask from the doctor.